Hey, welcome back to Not So Complicated, and this is another episode of USMLE First Aid Step 1 line to line, and we are tapping into obviously pathology. And today we are starting renal system. We have completed our general system, general principles, and then respiratory system, cardiovascular system, hematology and oncology, gastrointestinal system, and hepatobiliary system. And now we are tapping into renal pathology, and probably we will talk about this system for 2 sessions, and this is our first session where we will be covering nephritic syndrome and nephrotic syndrome. So stay tuned, and without further delay, let's begin. So let's talk about casts in urine. What are casts in urine? Different casts in urine are actually seen in renal diseases like RBC casts, and then WBC casts, granular casts, fatty casts, waxy casts, haline casts. These all are very important findings of urinary urinalysis, right? So these casts in urine are presence of casts, which is just substances or substrates kind of things that indicates that hematuria or pyuria is of glomerular or renal tubular origin. And in bladder cancer or kidney stones, there is hematuria and no casts. And then acute cystitis has pyuria and no casts. And all casts contain a matrix. All casts contain a matrix composed primarily of Tam-Hirschfeld mucoprotein, that is uromodulin. Tam-Hirschfeld mucoprotein is actually the protein that is present in the walls of urinary system, is a physiological process. These are the uromodulin, right? These are mucoproteins, and they get casted off from the wall when any disease is there. So they are secreted by renal tubular cells to prevent UTIs. They actually are believed to have immunological function, right? So they are believed to have immunological function, and these of note, I am adding some point in here, high yield point, that is Tam-Hirschfeld protein, then combined with IG, light chain of immunoglobulin light chain in the case of multiple myeloma, and that will create a different kind of cells that we call Baines-Jones proteins. And Baines-Jones proteins are typical particular finding of urinalysis in myeloma kidney. Okay, that is it. And then RBC casts, they are actually seen in glomerulonephritis and hypertensive emergencies, right, like this. And also in WBC cast, they are actually seen in tubular interstitial inflammation, acute pyelonephritis, and transplant rejection. So kidney transplant is done in the case of chronic kidney failure or acute kidney failure, bilateral kidney failure, right? So transplant is done. So in transplant, here is a fun fact that you can know. So in transplant, there is no removal of defective kidney, right? The kidney is there inside the body. So in a transplant patient of kidney, there are 3 kidneys in the body, but 2 of them or 1 of them are non-functional, right? So in granular casts, there is acute tubular necrosis. Granular casts are seen in acute tubular necrosis, and it can be muddy brown appearance. You can remember like this: muddy brown appearance is seen in acute tubular necrosis. And in fatty casts or oval fat bodies, they are usually seen in nephrotic syndrome, and we will talk why nephrotic syndrome. So it's fatty cast. We will talk about that in upcoming part, right? It is associated with Maltese cross sign. Maltese cross sign, you can see the figure here, Maltese cross sign, and these are granular casts actually. These yellow things, these are granular casts. These all are granular casts, and this is the sign here, Maltese crop sign. Okay, Maltese crop sign. Okay, in waxy casts are seen in end-stage renal disease and also chronic kidney disease. Haline casts are non-specific and can be a normal finding of dehydration, exercise, or diuretic therapy. These are haline casts. They are particularly less contrasted here, so it is not seen. So there is nomenclature. This is very important. This is very important for the upcoming concept. So we have to know the nomenclature of glomerular disorders, and that is focal, diffuse disorder, proliferative, membranous, primary glomerular disease, and secondary glomerular disease. This is very important for our upcoming class. Okay, not only upcoming class, this class, but in upcoming session. So in focal, there is 50% of glomeruli involved, less than 50%. That is focal. For example, let's say this is the glomerulus, right? So less than 50%, this part is involved, this is focal, okay, and this is glomerulus, another glomerulus, and this part is involved, this part is involved, this part is involved, this part is involved, and this is diffuse, that is more than 50% this glomeruli are involved, but diffusely, right? So, and also they are seen in diffuse proliferative glomerulonephritis, and they are seen in focal segmental glomerulosclerosis. And proliferative is hypercellular glomeruli, and that there are different causes to be hypercellular. There can be reactive glomerulosis, right? So, and also infiltration of inflammatory cells can be there. We'll talk about this in membranoproliferative glomerulonephritis while talking about nephritic syndrome in a tabulated format like a differential diagnosis. We'll talk about that. And in membranous case, there is thickening of GVM, right? So that is basement membrane, glomerular basement membrane thickening is there, and it is seen in membranous nephropathy. There are very underlying causes of this. We'll talk about these all things, right? So we just want to know about the nomenclature, what is said what, right? So in primary glomerular disease, there is primary disease of kidney, that is primary disease of kidney specifically impacting the glomeruli, and it is seen in minimal change disease, okay. And secondary glomerular disease is the systemic disease, a disease of another organ system that also impacts the glomeruli. That is the thing. It is not primarily in the kidney, right? So they are seen in SLE, systemic lupus erythematosus, and also in diabetic nephropathy, okay. That is what it is. Now let's begin glomerular diseases, where we talk about nephritic syndrome, nephrotic syndrome, and nephritic syndrome. Okay, so glomerular diseases right here, you can see the figure. This is glomerular capillary, okay, and this is endothelial cell, this is normal physiology, and then this is basement membrane right here, and this is podocyte. Podocytes are finger-like projections of cells, okay, and they form fenestrations here, and that is where the filtration occurs. And this is urinary Bowman space, and nephrotic syndrome actually occurs in these regions, okay. And nephrotic syndrome, this occurs in both, that carries both things in here, like protein and also RBC. But in nephrotic syndrome also protein and also RBC, and in nephritic syndrome it is exclusively RBC and little protein, okay. That is what it happens, and we will talk about pathophysiology of each of them, right? So let's talk about it. Nephritic syndrome. To begin with nephritic syndrome, the etiology of nephritic syndrome is glomerular inflammation, obviously, that will lead to glomerular basement membrane damage. Glomerular basement membrane is actually made up of type 4 collagen, if you don't know, and okay, that is it. And loss of RBCs into urine occurs, that is dysmorphic RBCs are found, and also hematuria is present in the case of nephritic syndrome. This is what it occurs, right? So glomerular inflammation is there, and then actually what happens is RBCs cannot get filtered out of the glomerulus because of their size and also negative charge. Since this glomerulus has actually negative charge in here, and RBC also has negative charge, right? That is usually applicable for albumin or protein, but in RBC case there is another reason. This RBC has hemoglobin, right? So RBC is actually bound to haptoglobin, and that haptoglobin doesn't let RBC to get filtered out of glomerulus. But when glomerular injury occurs, there is increase in size of the pore, right? So even if the haptoglobin binds, the RBCs can get filtered out, and that happens in the case of nephritic syndrome, causing dysmorphic RBCs in urinalysis and also hematuria. So clinical presentation is hematuria, that is RBC casts are found in urine, and decrease in GFR, which is causing oliguria and azotemia. Azotemia is increase in blood urea nitrogen, that is what occurs because there is filtration defect, and oliguria, and because there is decrease in filtration, as I had talked earlier, and there occurs also increase in renin release, okay. Renin release increases and hypertension occurs. So basically, renin release increases because there is oliguria, right? So there is a decrease in filtration, decrease in urine output that will sense that the juxtaglomerular cells will sense the outcome of this, and that will increase the release of renin, and renin will increase the release of angiotensinogen, and angiotensin to angiotensin 2 and aldosterone, that will lead to ultimately hypertension. And proteinuria is often subnephrotic range, that is less than 3.5 gram per day, which is greater than 3.5 gram per day in the case of nephrotic syndrome, but in severe cases may be in the nephrotic range, because if the glomerular inflammation is maximum, the pore size is maximum, right? So that is why it occurs. The examples are infection associated glomerulonephritis is in beta hemolytic streptococcus, so we'll talk about this, and Goodpasture syndrome. Goodpasture syndrome is actually the autoimmune disease, and what happens in this disease is that actually, as I had talked earlier, type 4 collagen, there is autoantibodies present against this type 4 collagen. Since there is the type 4 collagen is made that makes the glomerular basement membrane, there is disease in glomerular basement membrane, right? So not only that, but also in lungs there are glomerular basement membrane made up of type 4 collagen, so the symptoms also appear in lungs, causing hemoptysis, right? So hemoptysis is coughing out of blood. And IgA nephropathy is in Buerger's disease and Alport syndrome, and also membranoproliferative glomerulonephritis. These all are nephritic syndrome. Now talk about nephrotic syndrome, which is very important. And nephrotic syndrome, there is podocyte damage, and that will lead to impaired Charles barrier, causing proteinuria. So these podocytes are damaged, right? So there is what happens in nephrotic syndrome. In glomerulus, what happens is that let's say two factors affect the proteins. One is charge, another is size. Since the size of protein are actually larger than the pore size, they normally don't get filtered out. And also in albumin case, the albumin has negative charge, and also this wall of the glomerulus also have negative charge, so they actually repel in normal cases, right? But if there is damage in between these podocytes, the pore size also increases, and the repel is not enough, like the charge is not enough to repel the albumin, thus the albumin gets filtered out, and that will cause proteinuria. So proteinuria is a major feature of what? Nephrotic syndrome. So massive proteinuria is there, which is greater than 3.5 gram per day with edema. Now this proteinuria will lead to maximum number of symptoms, right? So with edema, because since albumin is what maintains the oncotic pressure, there is there is variability or variation in oncotic pressure that will lead to edema, and also hypoalbuminemia, because all the serum albumin is getting filtered out. And then hepatic lipogenesis occurs, because since albumin is a protein, right? So for this to compensate, there is compensatory rise of ApoB100 protein. So ApoB100 is a gamma globin, right? So ApoB100 is also a lipoprotein that will lead to increase in hepatic lipogenesis, thus hypertriglyceridemia or hypercholesterolemia. So frothy urine with fatty casts are also present in there because of the same reason. And it is associated with hypercoagulable state, as in renal vein thrombosis due to antithrombin loss in urine, and also increased risk of infection because loss of immunoglobulin G in urine, and soft tissue compromise, edema. Okay, compromised by edema. That is what the spectrum of symptoms are there, right? So in this case, and in this case, in nephritic syndrome, hypertension is often due to this oliguria. There is decrease in urine output that will lead to volume overload. Volume overload is causing hypertension. This hypertension is then again vicious cycle, causing what? The glomerular inflammation, and that will lead to hematuria and RBC cast in urine. That is also the reason. And the symptoms of the clinical manifestations of nephrotic syndrome are maybe primary, as in direct podocyte damage, or secondary, as in podocyte damage from systemic process, focal segmental glomerulonecrosis, sclerosis, as we have talked earlier. Focal is that specific part, segmental is also a specific part, and also glomerulosclerosis. And minimal change disease, we have membranous nephropathy, amyloidosis, and diabetic glomerulonephropathy. So nephritic nephrotic syndrome is actually the manifestation of kidney disease, but there are symptoms of both nephritic and nephrotic syndrome, right? So it occurs during severe GBM damage, which lead to loss of RBCs into urine plus impaired charge barrier, which will lead to hematuria plus proteinuria. So this is the finding. There is hematuria because there is severe GBM damage, and also proteinuria because there is impaired charge barrier. So that is why nephritic and nephrotic syndrome, nephritic spectrum is seen. Nephrotic proteinuria is there greater than 3.5 gram per day, and concomitant features of nephritic syndrome are there. So when this occurs, they occurs in any form of nephritic syndrome, but is most common with diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. That is it. So let's talk each of them. So beginning with nephritic syndrome, and then we'll talk about nephrotic syndrome, and that is how we wrap our class for today. Okay. In nephritic syndrome, let's begin with infection-related glomerulonephritis, that is type 3 hypersensitivity reaction with conjunctive hypocomplementemia. So actually infection-related, it means that there are the cases, right? Infection-related. So as in, what do you say? Staphylococcus, beta hemolyticus staphylococcus. This is basically seen in a patient where there is a preceding pharyngitis case. It's an small children of school age children, you can say 5 to 15 age of children. This is most commonly seen, and that is why. Why is that? Because staphylococcus is additional causative agent, obviously, and also beta A streptococcal pharyngitis causing, right? So group A streptococcal pharyngitis or infection. This cause is in 2 to 4 weeks after this infection. And why is that? Because there are antibodies made against this bacteria, right? But these antibodies then get deposited in the glomerular basement membrane or glomerulus, that will cause type 3 hypersensitivity reaction with conjunctive hypocomplementemia. So that is the mechanism. So in light microscopy, what we see is enlarged and hypercellular glomeruli is in this. Here you can see this glomeruli is enlarged for the one thing, and there is very hypercellular. You can see the imaging findings in here, right? So I will be making a video where we learn to read pathology slides like a pro, right? So probably I will upload it tomorrow in 3rd May, so you can visit it too. Okay, so in immunofluorescence, there is granular sky appearance, lumpy bumpy appearance, starry sky appearance, lumpy bumpy due to IgG, IgM, and C3 deposition along GBM and mesengium. You can see starry sky appearance. How beautiful it is, right? It looks so beautiful, but it is pathognomic. So sad. So there is starry sky appearance or lumpy bumpy appearance. You have to remember this. This is very high yield. And then in electron microscopy, there is subepithelial interstitial cell humps. That is how we remember. Now let's talk about IgA nephropathy, which is also called Burzer's disease. It occurs concurrently with respiratory or GI tract infections. IgA is secreted by mucosal linings, and renal pathology of IgA vasculitis occurs. That is what it happens. The mechanism is simple. There is mesangial proliferation, and then also IgA-based IC deposits in mesangium is seen in immunofluorescence, and in electron microscopy there is mesangial IgC deposits, and there is no specific findings here. You have to remember in this case, this infection-related case, starry sky appearance, lumpy bumpy appearance or granular appearance, and also subepithelial IC humps. You have to remember that. Let's talk about rapidly progressive crescentic glomerulonephritis. It has very poor prognosis, which means this is very rarely treated as normal cases, and the multiple cases are there, causes are there, that is in type 2 hypersensitivity reaction in Goodpasser syndrome. We talked about it, right? So Goodpasser syndrome is due to antibodies to GBM, and also here you can see there is crescent moon shaped in light microscopy. Crescent moon shaped, you can see crescent moon shape, right? This here, crescent moon shape, these regions here, you can see the figure, right? So crescent moon shaped appearance is there in our light microscopy. Crescents consist of fibrin and plasma proteins like C3b, complement 3b, with glomerular parietal cells, monocytes, and macrophages. So in immunofluorescence, what we see is linear immunofluorescence. This is very important. Very important. In rapidly progressive glomerulonephritis, there is linear deposition of immunoglobulins, and in almost all cases there are granular deposition. So you have to remember this. And there are antibodies against GBM, as I have talked earlier, more specifically type 4 collagen, and also alveolar basement membrane as in Goodpasture syndrome, and negative IF, or if there is nothing seen in immunofluorescence, that is in case of PLAB, there is no IgC3 deposition that occurs in granulomatosis with polyangiitis. That is a case of GPA, granulomatosis with polyangiitis. There might not be any immunofluorescence deposits. And PR3, ANCA, CANCA, eosinophilic granulomatosis with polyangiitis or microscopic polyangiitis as in MPO, ANCA, PANCA, and granular immunofluorescence as in PSGN and DPGN. Diffuse proliferative glomerulonephritis and post-streptococcal glomerulonephritis. That is it. So in electron microscopy, in Goodpasture syndrome, there are breaks in GVM and necrosis and crescent formation with no deposits. There is no deposits in the case of Goodpasture syndrome. And in PLAB, there is also no deposits. And EM, that is extracellular matrix features, depends on the underlying cause. That is it in rapid progressive glomerulonephritis. Let's talk about diffuse glomerulonephritis. It is often due to SLE, that is systemic erythematous lupus erythematosus, and think wire lupus. This is what occurs, wire lupus. So wire looping of capillaries are seen in diffuse proliferative. Here you can see there is wire looping, right? So wire looping of the capillaries occur in light microscopy. It is usually present in DPGN and MPGN, membranoproliferative glomerulonephritis, often present as nephritic and nephrotic syndrome. So this occurs in nephritic spectrum. There is granular deposition in immunofluorescence and also subendothelial, sometimes subepithelial or intramembranous IgG based interstitial cells, often with C3 deposition are seen. These are the typical features. So there is granular deposition in this case also. So let's talk about Alport syndrome, which is a very important syndrome. You have to remember this. There is a mutation of type 4 collagen. In earlier case, in Goodpasture syndrome, there was autoantibodies against glomerular basement membrane as in type 4 collagen. There is mutation in this case as in Alport syndrome. It is mostly X-linked dominant disease. X-linked dominant disease, and there are eye problems as in retinopathy, anterior lenticonus glomerulonephritis, sensory neural hearing loss, can't see, can't be, can't hear a B. That is it. Okay, this is the mnemonics: can't see, can't be, can't hear a tree. Can't hear a B. So there it occurs. There is sensory neural hearing loss, and also retinopathy, and also can't hear a B, obviously. And there are irregular thinning and thickening of splitting of glomerular basement membrane occurs in light microscopy, and in immunofluorescence there is initially negative, and also non-specific staining are seen, usually stays negative. And basket weave appearance, this is very high yield. In Alport syndrome, there is basket weave appearance in electron microscopy due to irregular thickening and longitudinal splitting of GVM. This is GVM. There is a splitting like this. This occurs. But in another cases, there are tram track afferents, as in this splitting. So this occurs in membranoproliferative glomerulonephritis. There can be type 1, maybe or maybe secondary to SBV, hepatitis B virus, hepatitis C virus infections, and type 2, which is associated with C3 nephritic factor. So IgG autoantibody that stabilizes C3 convertase enzyme will lead to persistent complement activation that will lead to decrease in C3. Okay. In light microscopy, there is mesangial ingrowth and GVAB splitting that will lead to tram track appearance in H and E, and also PAS staining. You can see in this arrow, tram track appearance. Okay, you have to remember this. And also there is granular deposition, as I have talked earlier. Only in RPGN cases there is linear immunofluorescence, but in all other cases there are granular immunofluorescence. There is type 1, you can see subendothelial IC deposits, and in type 2 you can see intramembranous deposits, also called dense deposit disease. This is the earlier term for type 2 membranoproliferative glomerulonephritis. That is how we finish our nephritic syndrome. Okay, there is parallel layer of Bowman capsule in here, afferent arteriole. This is mesangial deposition. Here you can see this deposition is mesangial deposition. This is mesangial cell, right? These are endothelial cells, and this is basement membrane right here. You can see this one is basement membrane, and this is intramembranous deposition. This is subendothelial deposition because these are endothelial cells. So subendothelial is beneath this endothelium, right? And subepithelial is beneath this epithelial porocytes. So that is how it occurs. There are two sides of GVM, and in one side there occurs subendothelial, and in the other side there occurs subepithelial deposition. That is how it occurs. Let's talk about nephrotic syndrome. There are different diseases in nephrotic syndrome, like minimal change disease, and then focal segmental glomerulosclerosis, membranous nephropathy, amyloidosis. We have talked about amyloidosis in our general principles. If you haven't watched the video, you can go and watch it in our YouTube. And also don't forget to subscribe if this is helping even a bit for you. And the mechanism of minimal change disease is that there is often primary. It is often primary, that is idiopathic. There is no known cause for this, and it is triggered by recent infection, immunization, or immune stimulation, that is 4 I's. Recent infection or immunization or immune stimulation, and or it can be idiopathic. There is 4 I's for minimal change disease. It is rarely secondary to lymphoma, cytokine mediated damage, or more common in children. This is very much common in children. And in light microscopy, what we can see is normal glomeruli, that is lipid may be seen in PT cells, that is proximal tubular cells. The immunofluorescence is negative in this case. This is very highly specific finding. Immunofluorescence is negative in minimal change disease, and also in post-immune rapidly progressive glomerulonephritis or crescentic GN. And that cases immunofluorescence is negative, and effacement of podocyte food processes are there. We have to remember this finding. This is very high yield finding. There is effacement of podocyte food processes. You can see food processes. Effacement means there is like it got out of the place where it usually used to be. That is effacement. And in focal segmental glomerulosclerosis, it can be primary as in idiopathic, or secondary as in HIV infection, sickle cell disease, obesity, or congenital malformations. It may progress to CKD, and this is more common in black people. Okay. So not black by black, but race like Negroes and Negroids. This is very common. Okay. And in light microscopy, there is segmental sclerosis and then helinosis. You can see segmental sclerosis. This is the sign of helinosis here. This is segmental sclerosis actually, and this is helinosis. You can see, right? And then Immunofluorescence is often negative but may be positive for non-specific focal deposits as in IgM and C3 and Cl, right? There is also effacement of podocyte food processes in focal segmental glomerulosclerosis. And in membranous nephropathy, it is also called membranous glomerulonephritis. It can be primary, for example, our antibodies to phospholipase A2 receptor. This is primary case. PLA2 receptor, you can remember like that. PLA2 receptor, this is very high yield, and they ask you in USMLE Step 2 one question. And also secondary to drugs, as in NSAIDs, penicillamine, gold. And infections like SBV, SCV, syphilis, SLE are solid tumors, and also increased risk of thromboembolism as in DVT and renal vein thrombosis can cause this. In light microscopy, there is diffuse capillary and GVM thickening. Okay. You can see prominently there is diffuse capillary and GVM thickening. You can see this is GVM thickening and these are capillary thickening right here. Okay. So in granular, due to immune complex deposition, and also spike dome appearance is seen due to subepithelial deposits. Spike and dome, this spike and then dome, spike dome appearance are seen in this case. Okay. And in amyloidosis, kidney most commonly involved organ. Obviously, it is associated with chronic conditions that predispose to amyloid deposition, as in AL amyloid, AA amyloid, and prolonged dialysis. We have talked about AL amyloid and AA amyloid previously in our general principles. If you haven't watched, you must watch that video. And also in light microscopy, there is Congo red stain which shows apple green birefringence. This is very, 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 very important. You have to remember this. Apple green birefringence, and this is due to polarized light due to amyloid deposition in the mesangium. Polarized light causes apple green birefringence in Congo red stain, not Abri stain. In Congo red stain, there is apple green birefringence in the case of amyloidosis. And in immunofluorescence, you can see AL amyloidosis, you can see maybe a positive for lambda and kappa light chains, and in AA amyloidosis, there is positive for AA protein. And in electron microscopy, you can see mesangial expansion of amyloid fibrils. Let's talk about diabetic glomerulonephropathy. We'll talk about this in detail in our endocrine system. So subscribe until for you get updated. Okay. So in diabetic glomerulonephropathy, there is most common cause of ESRD, which is end-stage renal disease in the United States, and also so hyperglycemia causes non-enzymatic glycation of tissue proteins that will lead to mesangial expansion that will lead to GVM thickening and increased permeability. GVM thickening and increased permeability. So hyperfiltration is in glomerular hypertension and also increased glomerular filtration rate will lead to glomerular hypertrophy because there is work overload, and also glomerular scarring is in glomerulosclerosis. So that will lead to further progression of nephropathy, and we have to look for albuminuria with increased urine albumin to creatinine ratio. And S inhibitors and ARBs are renoprotective for this case because they control hypertension, right? So in light microscopy, there is mesangial expansion, GVM thickening, eosinophilic nodular glomerulosclerosis, and there are Kimmel-Still-Wilson lesions. You have to remember this. Kimmel-Still-Wilson lesions. Here they are. Kimmel-Still-Wilson lesions in diabetic glomerulonephropathy, and they are non-specific staining and also usually negative in the case of immunofluorescence. So which one of that was negative? Minimal change disease was negative. Now there is diabetic glomerulonephropathy, which is also negative. There is prominent thickening of GBM with expanded mesangium in electron microscopy, predominantly due to increased mesangial matrix and segmental podocyte effacement. This is the reason why diabetic glomerulonephropathy looks like this in electron microscopy. So that is how we finish our nephritic syndrome, nephrotic syndrome, and also this nomenclature and cast in urine. We'll talk about our kidney stones like calcium, uric acid, cysteine stones, and then hydronephrosis, urinary incontinence. All the other remaining part of nephrology and urology we'll talk about in our upcoming sessions. And if you are still here, thank you so much for staying with me, and subscribe and also share this to your study group to expand the growth, because we all are going to smash the USMLE getting 260 plus. Thank you.